Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. And Brett, would you like to introduce yourself?
I'm Brett Tavares, and I'm an intern at the Blum Center this year.
Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use a chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you direct to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to hand it over to Brett, who will introduce you all today's guest speaker.
Hi, everyone. So joining us today, we have Dr. Bita Zahedi to give a talk on osteoporosis and fracture prevention. Dr. Zahedi is an endocrinologist at Mass General with a focus on metabolic bone disease, calcium imbalances, and pathophysiology of osteoporosis. She's a clinical faculty member at MGH's Endocrine Associates Clinic as well. She has created her internal medicine training at UMass Medical Center and fellowship in endocrinology, diabetes, and metabolism at Mass General. In addition to her clinical and research work, Dr. Zahedi enjoys formal teaching and mentoring at Harvard Medical students during their clinical training. Before I hand it over to Dr. Zahedi, Dr. Marcy Bolster, would you like to take a moment to introduce yourself?
I'd be happy to. Hi, good afternoon, everyone. I'm Marcy Bolster, and I'm a rheumatologist at Massachusetts General Hospital. I see patients with osteoporosis both in the rheumatology clinic as well as in the endocrinology clinic. And I'm the fellowship program director for the rheumatology fellowship program at MGH. And I'm delighted to be joining the talk today that Dr. Zahedi will lead. I will look at your questions in the chat and ask them to Dr. Zahedi at the end of the conference.
Please join us in welcoming Dr. Zahedi.
Thank you so much, Fred. Okay, I'm going to share my screen. Okay, and do you have my screen in the presenter mode?
Yes, looks great.
Okay, great. So, hello everyone. My name is Dr. Bita Zahedi. I'm at Mass General in the Endocrine Associates clinic. I'm very glad that you could all join us today. And our goal today is to learn about osteoporosis and how we can prevent fractures. So our objectives for the next 50 minutes or so is to distinguish the impact of bone health on fracture risk, talk about some of the prevention, screening, and treatment strategies, and also discuss some ongoing monitoring for osteopenia and osteoporosis. I want you all to be able to walk away with some actionable items on how you can improve your own bone health. So let's dive in. What is osteoporosis? So osteoporosis causes bone to lose density, become weak, and fracture easily. So osteoporosis is a disease. It's not a natural process as far as getting older. Now, osteoporosis may affect all bones throughout the body. And the reason why we want to screen for it and we care so much about it is because it increases our risk for fracture. So most fractures occur in the spine, and they can lead to deformity and disability. But there can also be other fractures like hip fractures that we know are associated with higher morbidity and mortality. So again, why do we care about osteoporosis? It's common. So 44 million Americans have low bone mineral density, and it's serious. So 1 in 2 women over the age of 50 will experience an osteoporotic fracture. And it's non-discriminatory, so it happens in men as well, 1 in 4 men over the age of 50. We know that we have good treatments for it, and using these treatments, we can reduce the risk of fracture by a good amount, by 50 to 70%. So since we know it's common, we know it's serious, and we have treatments for it, this is why we should kind of get engaged and talk about some things we can do to prevent it and manage it for the next hour. So some facts about fractures. 40% of women over the age of 50 will suffer an osteoporosis-related fracture in their lifetime. So that's a pretty high number. 2/3 of spine fractures are painless, so we don't even know that we have them. Now, fractures lead to disability and increased mortality. What do I mean by that? 5 to 8-fold higher in the first 3 months after sustained a fracture, as far as having another fracture. And also 20 to 25% increase in mortality as early as 1 year after a hip fracture. So now that we have a good understanding as far as why it's important and what it is, let's talk about some of the risk factors. Who is at the most risk? Postmenopausal women. So postmenopausal women, the reason for the postmenopause being that our bones are no longer at that stage being exposed to the same amount of estrogen as they have been. And the female sex is because of just the fact that our bones don't reach the same peak bone mineral density as men due to the testosterone that men have and for other reasons. Early menopause. What do I mean by early menopause? The average age of menopause is somewhere between 50 to 53. So early, anything in the early 40s or something like that, then you're presuming that the bones weren't exposed to the estrogen for as long as they would have been otherwise had menopause come at the mean age of 50. For that reason, this is a population that we want to be more aggressive with screening and things like that. Inadequate calcium or vitamin D, and I'll go through what I mean by inadequate in future slide. Parent with a hip fracture does increase our risk. White or Asian race are at a higher risk of developing osteoporosis, alcohol use and tobacco use, and certain medical conditions. So for example, type 1 diabetes increases our risk of developing osteoporosis by 5 to 7-folds, and type 2 diabetes increases our risk of developing osteoporosis by 2 to 3-folds. There are certain other conditions, including rheumatoid arthritis, that not just because of the medications used, but rather because of the disease itself predisposes one to having or being more likely to develop osteoporosis. Some other conditions that I've listed here are hyperthyroidism and hyperparathyroidism. Also some medications, including glucocorticoids. So some examples of those would be prednisone, prednisolone, dexamethasone. These are usually medications that are given for immunosuppression. So usually given for diseases that are autoimmune. For example, rheumatoid arthritis or psoriasis, things like that may require steroids. Breast or prostate cancer treatment. That comes from the fact that some of these treatments involve suppressing certain hormones, and we know that specific hormones are helpful for the bones, like we talked about estrogen and testosterone, and also seizure medications. Small body stature. So I do want to note that anorexia and conditions that lead to restrictive eating behavior and lower BMIs does increase one's risk of osteoporosis for multiple reasons. But even at normal BMI on the lower end, one's risk for developing osteoporosis can be increased. So now, what are some symptoms of osteoporosis? Usually there aren't any. So it's not like osteoarthritis where you can have like bones aching, joints aching, things like that. It's usually silent. And what do I mean by silent? So we don't know that bones are losing density. So they go from looking like this, and then as we get older, they can look like this, and we don't really know. What we can know sometimes based on the fractures that are caused by the osteoporosis. So here's an example of a vertebral fracture. Vertebra are the bone blocks that build up the spine. So this is vertebra kind of blown out so that you can see. And as you can see, this vertebra is fractured. So this is a type of fracture that we call a compression fracture, meaning it's sort of squished and compressed. And this can be painless, and a lot of the times patients don't know that they have it. The way that some notice it is that there is a decrease in their height. So if there is a height decrease more than a certain amount, that can alarm us into wanting to look into it further. Are there multiple vertebral fractures? Is there anything else going on? Now, other fractures that can be caused by osteoporosis, like hip, forearm, wrist fractures, those ones tend to be symptomatic, and we tend to know about them because they tend to be painful. So now I want to talk about what's a fragility fracture. Fragility fracture is a fall from a standing height or less that ought not to lead to a fracture, but it does. Now, what does that mean? So for example, here we have two images. We have, presumably it's a woman in her 20s and let's say a woman in her 70s or 80s. They're both falling on the same black sheet of ice. But while this one may just experience some pain and get up without a broken hip, she may have a broken hip. Both of them fell at a standing height, but it's her bone mineral density that is stronger and is protecting her from having an actual fracture, versus in this individual, this would or may lead to a fracture. So sometimes I hear patients say, no, anybody would have had a fracture with the fall I had. But the reason why we have this specifically defined as a fall from a standing height is without an injury. So not a motor vehicle accident, not, hit with a bat or something like that. A fall shouldn't technically lead to a fracture, because as we can see in this example, this person probably wouldn't have had a fracture while this person did. The other reason is because we know these types of fractures are associated with increased risk of a future fracture. So 1 in 5 patients with a fragility fracture will sustain a second fracture in the next 5 years. So it's important to be accepting that, hey, it's a fragility fracture, I should see my provider for it, because in effect, you'd be preventing the next fracture. So now how do we screen for osteoporosis? DEXA. So it's DXA, pronounced DEXA. It's a bone densometry, and it's an X-ray. It's an X-ray that measures multiple sites: hip, spine, and sometimes the wrist bone. And what it does is it looks a little something like this. So here you have the patient lying on the machine. This is the X-ray. There's a pillow to help position the patient. This is the care provider. You can see the image of the X-ray. And what they're doing is they're capturing a 2-dimensional image to help give us an idea of what the 3-dimensional bone may look like. Does it look like this? Meaning, is it normal? Does it look like this? Is it osteoporotic? Meaning there's a lot of porosities or holes within it? Or is it osteopenic? Meaning it's somewhere in between. Now, the things that I want to mention as far as the screening test is that it takes about 20 minutes or less. It's painless, and it is an X-ray, but it doesn't have a whole lot of radiation involved with it. What do I mean? So for example, if you were to have a chest X-ray because you had a pneumonia, the amount of radiation exposure with that would be 10 times higher than that one would be exposed to with a DEXA. So DEXA is rather considered a pretty good screening tool in the sense that it doesn't really expose one to a lot of radiation. Now, what the report provides is something called a T-score, which then I'll go over in future slides. But let's first talk about who needs a DEXA. So according to the National Osteoporosis Foundation, all women 65 years or older should have a DEXA. All women. So healthy or not, all women. Postmenopausal women with at least one risk factor. So if you reach menopause at age 53 and you're 55 and you have another risk factor, that person could be in need of a DEXA. Men, 70 years or older, especially with a risk factor. For example, a man that is, let's say he's a smoker, or has emphysema, is using a lot of steroids or things like that, that's someone that should get screened. And also adults with a history of fragility fracture, and fragility fracture as defined by the earlier slide. Also adults with disease or medication history with bone loss. Okay, so now we do the DEXA, we get a report. What does it tell us? It tells us the BMD, which stands for bone mineral density, which is basically density of the bone. Another thing it provides us is what's called a T-score. A T-score, a report, is a number of standard deviations by which the patient's bones are deviates from the mean of that of a healthy young individual. So for example, here we have a T-score of -1 or higher, meaning a more positive number, would be considered normal. But anything between -1 to -2.5 is considered osteopenia. -2.5 and lower is considered osteoporosis. Now, -2.5 with a fragility fracture or -3.5 without a fragility fracture would be considered severe osteoporosis. Now, what are these T-scores other than the standard deviation? What is that? I want to help conceptualize what that means. So for example, a T-score of -1 represents a 10% loss of bone mass compared with the mean young normal adult. Every change of T-score by 1 is equivalent to a doubling of fracture risk. So when you see this, you think, wow, so even if, let's say, I'm in the osteopenic range, you see with the T-score of, let's say, -2, you're at a 4 times increase risk of a fracture. So it helps kind of conceptualize that it's all a spectrum. And the question is, at which part within the spectrum do we want to treat or intervene? Now, one of the tools that helps us in the determination of that is what's called a FRAX calculator. So a FRAX calculator, this is what it looks like, and it takes into account different risk factors that we already covered, such as age, sex, weight, height, previous fracture, parent with a hip fracture, smoking, glucocorticoids, rheumatoid arthritis, alcohol, other reasons for having osteoporosis. And even without a bone mineral density, you can plug it in and it'll give you 2 numbers. And I'll explain what those 2 numbers are. But if you do have a DEXA and you have a bone mineral density, it'll give you an even more accurate depiction of what those numbers are. Now, what are those? Those numbers are your 10-year fracture rate probability of 2 things. 1, a major osteoporotic fracture. And what is that defined by? A fracture of spine, hip, forearm, or the shoulder. And the second number is your 10-year probability of a hip fracture. Now, as healthcare providers, if those numbers are higher than a certain threshold, even with a T-score that may be in the osteopenic range, we would determine that this patient or this person may benefit from treatment. So this is where FRAX calculator helps kind of determine who may need intervention. So now let's talk about how do we prevent fractures. So 1, strengthening your bones. We all know that calcium's good for you, and vitamin D for the bones, but we don't know how much. So every day, for folks above the age of 50 particularly, we need at least 1,000 to 1,200 milligrams of calcium, and also 1,000 international units of vitamin D. Now, what does that amount to? So we recommend that you get it from your diet mostly, because the calcium that's in the diet is absorbed better. But there are supplements which one can use to kind of supplement the rest of the deficit of the calcium from the diet. Now, an example of a Centrum Silver for women multivitamin, this is what the back of the bottle looks like. A few things I want you to pay attention to. 1 is the serving size, because serving size is not always 1 tablet. Sometimes it's 2 tablets. So it's important to know that these numbers apply to the serving size. So if the serving size is 2 tablets and you're taking 1 tablet, these numbers don't apply to you. You're getting half of that amount. So 1, pay attention to the serving size. 2, pay attention to the back of the bottle and look at what the calcium content is and what the vitamin D content is. Here we see vitamin D content is 1,000 units, so that is sufficient. but the calcium we see is 300 milligrams. Now, if we said we need about 1,000 to 1,200, this doesn't meet the full day's worth. So what you want to do is supplement that with some more calcium within your diet. Now, what do I mean by within your diet? Mostly dairy products are rich in calcium, but there are other food products that are not dairy that also have calcium. And there's a lot of calcium fortified foods. So for example, here are a few examples that I included. Milk. It doesn't matter if it's skim milk. It doesn't matter if it's whole milk. That's just the calories and the fat content. All milk would have calcium in it. And for example, a glass of milk would have about 300 milligrams of calcium. A cup of yogurt would have about 250 to 400 milligrams of calcium. The reason why that's variable is that it varies based on the brand. Swiss cheese, an ounce of it, 270 milligrams. Softer cheese like cottage cheese would be less. Now, if this person was taking 1 tablet a day, they're getting 300 milligrams. They had a glass of milk with breakfast, had a yogurt for a snack, and had some cheese sprinkled into their salad, that would meet their daily requirement of calcium. Now, for vitamin D, a good source of vitamin D is usually fortified foods or supplements. But for example, milk has about 100 international units per glass, and most multivitamins have about 400 international units. Especially living in New England, it's very important to take note of how much your own multivitamin or supplement have as far as the vitamin D. So now I want to talk about fracture prevention. What can we do? Weight-bearing exercises. First and foremost, it's important that you check with your physician whether you can engage in exercise, because sometimes, someone is right out of, having a broken bone or surgery, and they may not be able to engage in certain exercises. So consult with your doctor first. But in the next slide, I'll go over what some of the examples of those weight-bearing exercises are. In the meantime, I'll tell you why and how these are helpful, because they help with bone mass and bone strength, they enhance muscle strength, decrease risk of falling, increase flexibility of soft tissues, they improve balance and help us with better posture, they improve cardiovascular fitness, and also even help with depression. So some of these exercises include low-impact weight-bearing exercises, walking, dancing, stair climbing, gardening. Some of the other ones like swimming and cycling, although they do have benefits, like cardiovascular benefits, they're not necessarily weight-bearing. So they're not putting a weight-bearing load onto the bones. So it's not necessarily helping the bone mineral loss. Now, that's important to note, because if you want to do something for your bones in particular, and you're only cycling or doing something like that, it's important to incorporate a weight-bearing exercise, because that by definition would be a different type of exercise. For upper extremities, recommend lifting weights. And there's a lot of resources. Make sure that you vet them correctly. There's a lot of beginner videos, exercise workout videos for osteoporosis and things like that you can use to help incorporate exercise in your daily routine. You don't necessarily need to go to a gym or have a membership or have all that. This is something that you can do on your own, at your own home, by just adding in a little bit of exercise in your day. If you do have osteoporosis, it's important to avoid high impact and bending and twisting. This is important because there's an overlap as far as this population in arthritis or having other problems where it can lead to fractures and other things that may be aside from the osteoporosis. Now, fall prevention. In New England, there's a lot of older homes, and not all of them are up to par as far as the guidelines and things like that. So I want you all to take note of what your environment looks like as we're all aging, and make that environment as safe as possible for you to prevent future falls. For example, using handrails on stairs and bathrooms, freeing rooms of clutter, floors being clean but not slippery. So here are some examples of don't do's. You see the rugs? So when you go from the wood floor to the rug, easy to trip there. See this little distance between the wood floor and the little platform? Easily you can trip over that. This crack in the wood, can get caught in that. Now these stairs, there are different heights. So when you're taking a step, your mind thinks this is going to be the same height as this, but you overstep, have a fall forward, can easily fracture. No landing, no handrails. So there's a lot going on there. So you want to look at your own environment that you are exposed to the most and kind of try and optimize it as far as safety. What are some other things you can do? You can stand up slowly, wear supportive low-heeled shoes, don't walk in socks or floppy slippers, install ceiling lighting, well-lit rooms, and also have a flashlight at the bedside or use a night light. Use a rubber mat in the shower to help prevent slips. Avoid or limit the alcohol intake. Okay, so this is what I have for osteoporosis and falls and things like that. The rest of the talk, I want to focus on osteoporosis treatment and medications. So we have a lot of medications compared to, 30 years ago or so. This breakdown is based on how often the medication needs to be taken. So daily, we have raloxifene, teriparatide, abaloparatide. I've also included the pharmaceutical names for it. That's easier to remember. And indicated which ones are subcutaneous, meaning an injection. These ones are pills, and they're weekly, alendronate and recitronate. These ones are monthly. And this one is a twice-a-year injection. And a yearly infusion, an infusion indicating that it goes directly to the bloodstream rather than an injection going into the tissue. And this one is called zoledronic acid, and it's a once-a-year medication. So we'll talk about all of these specifically. So big picture is think about of osteoporosis therapy in two buckets. One is antiresorptive, meaning you want to reduce bone loss. So you don't want to lose any more bone. That would be a bisphosphonates, which I'll talk about what medications fall under that umbrella, and denosumab. That's a twice-a-year medication. Or anabolic agents. This bucket builds more bone. An example of what would fall under this category is PTH analogs, or parathyroid hormone analogs. A newer medication called romosozumab falls under both categories, meaning it's both antiresorptive as well as anabolic. So now let's talk about each one of these classes. For antiresorptive, we talked about bisphosphonates. That's the one that's been around the longest. Here are the 3 oral medications. Usually, it's used between 3 to 6 years at a time. The big thing with it is esophageal discomfort. So we don't really give it to patients that already have a lot of reflux or a lot of gastrointestinal issues and things like that. How you want to make sure you're taking this medication is in the morning, empty stomach, whole glass of water, without any food or drinks, and don't lie back down for 30 minutes. So just make sure that it goes down and it gets absorbed well. Now, the infusion, that's also, that I mentioned, zoledronic acid, that's also bisphosphonate, but it's a once-a-year medication. This one is given for 2 to 3 years, so 2 to 3 doses. The big thing with this medication is that approximately 30% of patients, so about a third, on the day that they get this infusion, they have some flu-like symptoms. So similar to maybe having had the COVID vaccine, the day of, they feel a little run down. It shouldn't last longer than a day or two. What we recommend to minimize the risk of that is hydrate. And if your other medical conditions allow for it, take a Tylenol or an ibuprofen before the infusion to help minimize some of that. 2 of the other adverse effects I'll call osteonecrosis of the jaw and atypical femur fracture. You'll see that this is a common theme for the other medications that I'll be talking about as well. So at the end, I will go through each one of these side effects and explain it further. So now let's talk about that injections twice a year, or denosumab. Again, this is an antiresorptive, so you're minimizing bone loss. It's used for about 2 years. The big thing to note for this medication is that the risk of multiple vertebral fractures is increased if a dose is missed or immediately after discontinuation. For that reason, right after discontinuation, whenever it may be, like let's say 6 months later, you need to be given another anti-osteoporotic medication to help mitigate this issue. So it's absolutely safe as long as we do that, but it's very important to know a dose cannot be missed because it does increase the risk of a vertebral fracture. Some of the side effects with it can be eczema at the site of the injection, and those two conditions that we'll go into in detail. Anabolic therapy. So now we're building more bone. PTH analogs or parathyroid hormone analogs. These medications, teriparatide and abaloparatide, they are both injections, and they're often considered for folks with severe osteoporosis. Now, how they're used is they're often used for 1 to 2 years, and they're not to be used in patients or people that are at an increased risk for a type of bone cancer called osteosarcoma, patients with certain bone disease called Paget's disease, or radiation therapy to the bone, or elevated alkaline phosphatase, which is a blood work. Some of the common side effects could be leg cramps or dizziness. Now, this is the newest medication called romosozumab. This medication is both antiresorptive and anabolic. It's often used for 1 to 2 years. And there's a black box warning regarding the possibility for increased risk of MI, which is basically a heart attack, myocardial infarction, stroke, and cardiovascular death. For that reason, we don't really start people on it if they've had a heart attack or an MI or a stroke within the past year. Now, there's a lot of data about this as far as the risk of MI and things like that, but it's unclear. So basically, there was 2 large studies. One of them, they looked at about 7,000 individuals, and they saw one group got romosozumab, another group, which is called the placebo group. Now, of the group that received placebo, 1.1% had a cardiac event. 1.2% of the romosozumab had a cardiac event. So here they said there was no significant difference. No, it doesn't do that. Second study looked at romosozumab versus alendronate. That's the oral bisphosphonate. And in this study, they looked at 4,000 women, and they saw that there was 1.9% of women receiving the placebo that had a serious cardiovascular event versus 2.5% that received romosozumab had a cardiovascular event. In that study, they concluded that there is a significant difference. Now, it's not clear why the 2 studies had conflicting results, but in many patients, if the benefits outweigh the risks, even considering that cardiovascular risk may be increased modestly, we may still consider it. Some of the side effects would be fast heartbeat or palpitations, skin rash or hives, osteonecrosis of the jaw, and atypical femur fractures. Okay, so now let's talk about those 2 big ones that I know often patients ask me about because they've either seen it on TV, call so-and-so's law firm if you think you've had this, or have heard about osteonecrosis of the jaw, and they want to learn more about it. So osteonecrosis of the jaw basically means poor wound healing of the jawbone. So it occurs when the bone is exposed and has poor blood supply. It's seen most often in patients that received IV, meaning intravenous treatment for cancer, who have high calcium levels. Now, the risk factors for this is high doses. So for example, in the case of the IV treatment for cancer, there are at much higher doses, much higher frequency. So about 10 times higher than, the doses that are used for osteoporosis alone. Another big risk factor is poor dental hygiene. So dental trauma, surgery that involves the jawbone, like a dental extraction, things like that. So filling, general checkups, all of that is fine because it doesn't really involve the jaw bone. But for example, a dental extraction, that's getting pulled out of the jaw bone so that you want the jaw bone to heal. So that's different. How can we minimize that, maintain good dental hygiene, and also complete dental work prior to treatment initiation? Now, it doesn't preclude one if they still need to have some dental work done while they're on treatment for osteoporosis. In a case like that, you work with your oral surgeon to help give you as much time away from your last dose to help minimize some of that risk of the osteonecrosis of the jaw. Now, the other big one that we talked about was, or well, actually, before I go to the other one, this I think is a very helpful figure. So here you see one that, for example, at the risk of having any fragility fracture is 2,668. Risk of having a hip fracture is 387 for every 0.7 patients that has ONJ. So you see how many fragility fractures and hip fractures you're preventing and how low the risk of osteoporosis, or excuse me, ONJ based on osteoporosis medication is. When you put it in context of how much the benefits outweigh the risks, it kind of helps us decide. Now, the other big one that we talked about is atypical femur fracture. What is this? So it's a fragility of the thigh bone or the femur. Its association determined but not causal, meaning studies have shown that there's higher rates, but we don't know that this is the cause. Now, it also occurs among adults that have never been on bisphosphonates. It's not to say that bisphosphonate is the only cause or something like that. And it's reassuring to note that once the medication is stopped, even quickly after, so 70% decline in the risk each year that you're off of the medication. Now, this is an image that I find helpful for this case. For every 1,200 fractures prevented, one atypical femur fracture is caused. So that means that one atypical femur fracture, as far as epidemiologically speaking, you're preventing 850 vertebral fractures. You would have treated 220 people that would have had non-vertebral fractures, 130 that would have had hip fractures. So you see, again, in the context, that benefits do indeed outweigh the risks when it comes to most osteoporosis medications and those risk factors that may have been previously more advertised to the public. So now let's talk about monitoring treatment. So when you start on the treatment, it doesn't mean it's the end of it, we monitor it. So we continue to monitor it using DEXA, the imaging device, every 2 years to see which direction we're going. We're also monitored for new fractures. Occasionally we can do some blood work because there's certain blood markers or urine markers that tell us whether there is increased bone breakdown. Now, sometimes you can consider switching to therapy if there is a fracture while you're on a certain treatment. We may want to move to a more, become more aggressive with our treatment. So we still want to continue to monitor you while you're on treatment. Now, there's something called a drug holiday. What's a drug holiday? So a drug holiday is basically, as the name implies, a holiday from taking the medication. Why? We don't want you to be on these medications for lifelong, and you don't need to be on them for lifelong. So after you're on it for a certain period of time, what we do is we do some imaging, like a bone density scan or something like that, to see whether you can qualify for being off of the medication, meaning you are now not at that concerning threshold. Be off of the medications, have the drug holiday for a few years, continue to monitor you during this time so that if the bone mineral density continues to drop, or if you have other risk factors that would put you at a different risk category, you may be reinitiated back on therapy so that we can catch it when it's the time to reinitiate as well. But it's reassuring to know that that is a possibility to be off of the medication for a certain period of time, and that does apply to some folks. But it's also noteworthy that Don't be afraid if you need to be reinitiated. A lot of times that's the case. You get some time off and then you need to be reinitiated back on it once the bone mineral density drops more than a certain amount. Now, the duration of the drug holiday depends on a lot of risk factors: patient's age, other risk factors, history of fractures, other medical illnesses, and things like that. So it's not something that you should do on your own, but it's something that you can bring up to your healthcare provider and say, hey, would I qualify for a drug holiday? If so, when can we visit this? Now, bone turnover can resume, like we said. So it's not that, even though a lot of these medications stay in your bones for a while and can continue to protect you, bone turnover can resume, meaning you can start to lose bone again. In that case, we want to keep a close eye on you even during that drug holiday period to know when we need to reinitiate treatment. The other thing to note, during the drug holiday, you're not fully off the hook. You got to make sure you're still keeping up with your calcium. You got to make sure you're keeping up with your vitamin D. You're still engaging in weight-bearing exercises. So, know that was a whirlwind of osteoporosis. So let's talk about what can you do. So we talked about the supplements and the minerals that we need. 1,000 to 1,200 milligrams of calcium in your diet, preferably from the diet. But if you can't get it from the diet, use supplements. Make sure you read the back of the bottle and also look at the serving size. Talked about the vitamin D, 1,000 international units a day. Engage in weight-bearing exercises. Before you do that, ask your doctor. Look into what exercises are considered weight-bearing. Make sure it includes both lower extremities and upper extremities. So also maybe do some lifting. And also ask your doctor if you should be screened for osteoporosis. Because, when we go see our primary cares, there's a lot going on. We need to do mammograms. We need to do colonoscopies. There's a lot of different screenings that needs to be done. And given you are on this talk, tells me that you're very engaged with your healthcare. So I want you to be an active component of this decision-making process and say, hey, when should I be screened for osteoporosis? I'm postmenopausal. I may have this risk factor. Should I be screened sooner? Bring that up to your physician. Minimize your risk of falls. So as we age, look at your house and see what things can you change, what things can you improve to make it safer. Stay engaged in your treatment and follow-up plans. So continue to stay engaged. Once you start on the medication, that doesn't mean you're done. Keep up with the calcium, with the vitamin D, with the exercise. Keep up with your visits and the follow-ups. Make sure that you're not having another fracture. Make sure you're doing the monitoring screenings and things like that. So that's all that I have for you. The next slides, this is a study that we are doing as far as diabetes and bone. If you're interested, there's a contact information. And here are some resources. This is a wonderful book written by Dr. Bolster that is meant for patients, and it's a guide for for patients and also your families as far as osteoporosis, treatments, and things of that nature. So here I'm going to stop sharing my screen.
Dr. Zahedi, that was wonderful. Thank you so much. And I think the summary that you provided at the end was very helpful. Thanks to all the attendees. We have several questions in the chat. So I'm going to ask the questions to you, Dr. Zahedi, if you want to take these, okay? The first question was, do steroid inhalers increase the risk for osteoporosis?
That's a great question. Most of the studies have been done on oral steroids, but we have seen a lot of cases with other methods of administration steroids. For example, if you're getting a lot of joint injections, so sometimes for arthritis or stenosis or other back issues or joint problems, we get a lot of injections. If they're becoming more and more frequent, that can lead to bone loss. Now, inhaled steroids, it's not as clear, but if I had to derive a conclusion based on that, based on the fact that we see a lot of cases with the injections, I would say if it's at large doses, if it's frequent, if it's lifelong, that is something that I would certainly consider.
Okay, thank you. This is a two-part question. What tests help detect osteonecrosis of the jaw at an early stage, and what specialists should be involved in the care?
So the good thing about osteonecrosis of the jaw is that it's usually painful. So it's associated with pain. So it usually does not go unnoticed. Now, how can you pick it up early? Routine dental care. So the folks that are best equipped to check that are folks that are providing you dental care. Because even though as rheumatologists or as endocrinologists, we're giving these medications, we check your mouth, we're not able to fully examine your jawbone, but the dentists or the oral surgeons can. So one, if you are on these medications, I would mention it to your oral healthcare providers to make sure that they're aware that's in the chart, that's something they're looking for. Now, specifically, as far as what are some tests you can do, there are certain imagings that can be done where you can start to see some effects of the osteonecrosis. Again, this becomes a concern in cases where there's poor dentition, very high doses, or where there is invasive oral procedures like dental extractions or things that has to do with the jawbone.
That's very helpful. And I think you're right. I think keeping it in perspective that it's a very rare complication is so important. Your slide with the graph showing the relative risk for different outcomes, I think was very helpful. There's a question. This is a really interesting, there's actually kind of a commentary that's in the chat, and it talks about this talk in particular is very helpful for educating the community and patients who may have osteoporosis or who are at risk for osteoporosis. But can you comment on the role of the primary care provider and how that clinician is positioned in this care pathway?
Yeah, so we certainly appreciate our primary care provider colleagues that are helping with screenings and things like that. That's, I would say, for the most part, where they come in is screening and picking up these cases. The other piece is starting on medications. So I know I talked about a lot of different treatments, but still our kind of, it's called bread and butter, our go-tos are the bisphosphonates. And if patients don't have any contraindications, means they don't have any GI side effects, they don't have any reflux, any swallowing issues, an oral bisphosphonate would be a completely reasonable choice to start with. And most times, primary care physicians start patients on that. Now, usually when we get the referrals, although we'd be happy to see it anytime, it is when it gets a little bit more complicated. For example, you're on that medication and you have a hip fracture. What should we do? How can we be more aggressive? Or in a patient that's very young and has very severe osteoporosis, how should we approach this? Should we be more aggressive from the get-go? So usually in those cases, it gets a little bit more specialized or subspecialized. But for the most part, I want to empower our primary care colleagues that this is certainly something within their wheelhouse as well.
Right, that's absolutely true. And I think you also, in your talk today, you've empowered patients to be able to bring the topic up with their primary care provider. And that can be, it's just an important part, as you mentioned, for people to be engaged in their own healthcare to improve outcomes. Someone has asked, what is the Z-score on the bone density test?
That's a very good and astute question. So there is the T-score and there's a Z-score. The T-score compares your bone to the bone of a 30-year-old healthy woman, while the Z-score accounts for the sex, age, and race, meaning the Z-score is comparing your bone to more, say, your peers. So then the next question is, well, which number do I use? Which number do I go off of? Most of the studies that look at risk of fracture and things like that are using T-scores, and that's usually what we go off of is T-score. But in certain cases, for example, in, let's say, pediatrics or in premenopausal women, in those cases, we look at the Z-score because those numbers would be different. Because, for example, in a pediatric patient, it'd be unfair to compare it to a 30-year-old woman when they haven't reached that peak bone mass yet.
And do you find that Z-scores can be used in the postmenopausal population?
Usually we don't use Z-scores in the postmenopausal women because T-scores are the ones, again, that are used as far as studies that tell us, okay, you have twofold risk of X, Y, and Z. So that's why we go off of the T-score for postmenopausal women in particular.
Right. And I think, I think that's exactly right. It's really important to focus on the T-score. And the Z-score has slightly different ranges to use to look at whether a patient has the expected bone mass for someone their age. Sometimes I think the Z-score can be used in postmenopausal women or men over 50, because if it's exceptionally low, then it might give us a clue that there's another underlying condition that may be superimposed on the osteoporosis. All right, there's going to be one last question and then we can wrap up. And that is, how many years can bisphosphonates be taken?
So it's a great question in the sense that you're thinking about the kind of long-term goal. Again, like as we mentioned, these are in lifelong medications, but there are different types of bisphosphonates. For example, the number of years that would allot to an oral would be different than the IV. But usually, as a rule of thumb, again, this is crudely, for oral bisphosphonates, we use them for about 3 to 5 years at a time and consider drug holiday. But that's not to say that over a lifetime, it needs to be 3 to 5 years only. A lot of times do that, give you a drug holiday, and then you can be resumed back on it. And same with zoledronic acid, which is the IV form. Usually give 2 or 3 doses, drug holiday, and then you can be back on it. Now, the concern for why we want to give the drug holiday, again, is to minimize those risks or those adverse effects, which, as we mentioned, were seen in very high doses and higher frequency. So it's still not, truly concerning to, have someone be on zoledronic acid for 3 years, have a drug holiday, and then get a couple of doses again. That's not really the population that we see those adverse effects in. Now, there isn't really a true cap, sort of say, as far as when do you have to stop bisphosphonates. It's always a discussion and a risk and benefit ratio, because if the risk of fracture is still pretty high, then that's something that still needs to be considered.
Right, I completely agree. Dr. Zahedi, this has been a fantastic presentation. Thank you for leading this discussion. I think it's been very informative. The questions in the chat were wonderful. I'm delighted that we have over 40 attendees. So thanks very much to you and also to the Blum Center.
Yes, thank you. Thank you guys so much. And thank you for attending.
Thank you, everyone. Have a lovely rest of the day.
Thank you.
Bye-bye.